diagnosed her with PPROM at that time, if she wasn't laboring, there could have been an opportunity to transfer that patient to a place that had a NICU. We'd also might have given her the opportunity to receive the 2 doses of betamethasone. I know we got 1 dose in, but the patient delivered too quickly for us to get a 2nd dose in. Again, no antibiotics were able to be given. The white blood cell count when patient first arrived was normal, so we might have been able to hold off an infection that was brewing if we had started her on antibiotics maybe a couple of days prior, I think are the big things.
I see that Dr. Siegel has his hand up.
So, nice presentation. Along the same lines as Dr. Ebert. So you said there was a miscommunication between the ER and
Yes.
OB?
Yes. So what I think had happened was the ED had called up when the patient first arrived. The patient was mostly complaining of shortness of breath and that headache, and then also had some leakage of fluid that she endorsed. They had gotten a fetal heart rate downstairs, but how it typically had worked at that institution was that the ED would clear them from the standpoint of maybe the shortness of breath and headache, and then transfer them upstairs for their obstetric complaints. So that was what the OB team had told the ED. I think there might have been a change of shift or something that happened where they had just discharged the patient immediately upon clearing the patient instead of sending her upstairs.
Did anyone from the OB team call her, say, come in?
Not that I had seen in the chart.
Yeah, we're going to get killed on that.
Yeah.
So, yeah. And the other thing is, I've always railed against this, and I've always been back and forth. Is when you have a viable infant and the patient comes in, we think it's easier for them to be checked out at the ED because they can do a CAT scan for PE when she was standing at 100% in the first place, right?
Yeah.
Right. We do this all the time because it's more convenient. But the thing is, we're losing the opportunity to check on this baby acutely, or at least initially, for hours. You don't know anything for hours. And my recommendation has been in the past, but again, every institution is different, is to see these people on labor and delivery, because we're the ER for viable patients, and then do everything from there. We order the PTA, we do that workup. Unless that you think the person is in a massive trauma and needs acute, surgical intervention.
Mm-hmm.
Maybe the change of protocol needs to be. We've had this before. We've missed things because they're not checking the second patient out.
Yes, and I think at this institution they had started to change their policies around that because of this situation. So I definitely agree with you.
Here at Robert Wood Johnson, it is always an option to ask the labor and delivery nurses to go down and monitor the patient in the emergency room. Mm-hmm. And I've always asked for that, and it's always been done.
So I have asked for the same thing, Gary, over the year, Dr. Eber, over the years. Sometimes it's not enough staff to do so. That's my problem. Where they say the initial reaction to the floor is that no, this person should be cleared in the ER first. You're like, wait a second, they're not going to monitor the baby at all. You can't send anybody. Residents should know you have the opportunity to bring her upstairs and you do the workup. You have that opportunity also.
Dr. Pradhan?
Yeah, just follow up on that miscommunication. Important that, we're talking about it here, but that I'm sure they're reviewing it at their QI meeting at that hospital. But that piece about the miscommunication is so important. But the other thing I was thinking that we could do always, even as we have a plan, we should also share it with the patient, right? So the patient could say, no, but the doctor told me I need to do this, as another safety net in terms of helping that miscommunication. And I know we have our grand round speaker starting at 8. So I just want everybody to think about this on their own and make sure you know the answer to why we gave the extra dose of Clinda after the baby was out, and to think about where in this patient's history the gastric sleeve happened. So I'm going to prenatal care now, as opposed to that moment in time when she came into the ER, and how gastric sleeve affects pregnancy outcomes. A whole longer discussion, but points for us to think about and have conversations about as we're hanging out in other spaces.
All right. Well, as Dr. Pradhan mentioned, it is time to switch gears and transition to grand rounds. Thank you, Marissa, for presenting those two very educational cases. So in just a minute, I'm going to ask Dr. Bayat to introduce our grand round speaker. But in the meantime, regarding attendance, we'll be taking attendance for the department purposes at 8:10. If your name is displayed clearly, you'll get full credit for attendance. But if you've called in or if your name isn't clear, you can email Michelle or Beth or I regarding your attendance. And with that, Dr. Bayat, are you ready to introduce our speaker?
I am. Can you hear me okay?
Yes, loud and clear.
Okay. Good morning, everybody. Dr. Krishna, thank you so much for joining us this morning and for sharing your expertise with us. Dr. Krishna started her career at Brown University, where she completed both her undergraduate degree, which she earned with honors, by the way, as well as her medical degree. At that time, she had already established her dedication to reproductive health, and was serving on the National Board of Directors for Medical Students for Choice, which for those of us who know the field of complex family planning is a big deal. She subsequently went on to Emory University to complete her OBGYN residency, followed by Columbia for her fellowship in complex family planning. And now I imagine that she is doing the hardest part of her career and perhaps even the most meaningful and impactful, which is to serve as an assistant professor in complex family planning at Emory in a state where there's a constant battle between being able to do your job as an OBGYN and what the state allows you to do. So it is with genuine appreciation and privilege and pleasure that we welcome you, Dr. Krishna. Thank you so much for doing the work that you do in a battleground state. That's work that is harder than most of us could ever do. So thank you for that. And thank you so much for joining us this morning. It's really a privilege and pleasure.
Thank you so much for that generous introduction, Dr. Bayat. I'm very excited for the privilege to speak to you all today on this topic. The guidance that I will be presenting from this talk are largely adapted from clinical guidance from ACOG, the Society for Family Planning, or SFP, or Society for Maternal Fetal Medicine, unless I've noted otherwise. I did want to give a little bit of a, not sort of a financial disclosure, but more of a personal disclosure about my own background and then this talk as well. As Dr. Bayat mentioned, I have trained both in states with very restrictive abortion laws and states with more permissive abortion laws. And so I have seen kind of the full gamut of how medical professionals are able to provide care based on legal restrictions and how we modify that to really make sure that our patients get the standard of care as best that we can. So I'm happy to speak a little bit more about my personal experiences, but try to focus a little bit more on just evidence-based guidelines for the purposes of this talk. This presentation was originally one that I gave for a critical care in obstetrics talk about a year ago. And I thought a little bit about changing the title because I know that we really want to destigmatize terminology around abortion, but I thought that it would be a good opportunity to make a note about terminology. Given that management options for second trimester pregnancy loss is essentially the same of second trimester abortion, this is a moment to remind everyone that these terms can be used interchangeably. And additionally, between guidelines from SMFM and SFP, it's important to note that qualifiers such as indicated or elective when describing abortion care are not medically necessary when we discuss our clinical practice, and may also further stigmatize abortion and patients seeking that care. I have three main objectives for this talk. So first, I will evaluate techniques for second trimester abortion. Secondly, I will discuss managing urgent uterine evacuation in the second trimester. And finally, I will discuss abortion-related complications. As you may know, the majority of abortions occur in the first trimester, with only 1% occurring after 20 weeks. While second trimester abortion is less common, there are many reasons why people may seek this care. Abortion may be for an undesired pregnancy, especially if people were unable to access care in the first trimester due to barriers such as restrictive laws or lack of insurance coverage. Additionally, people may also seek abortion for fetal anomalies, many of which are not diagnosed until anatomy ultrasounds later in the second trimester. Certain maternal health complications such as preeclampsia or placenta previa may not arise until the second trimester. And lastly, as I described before, the techniques used for abortion in the second trimester are the same for managing pregnancy loss at this gestational period as well. Given all of these reasons for second trimester abortion, it's important for us as OBGYNs to be familiar with these methods for counseling patients. Second trimester abortion can occur through procedures or through medication. And first, I'll go through the procedural aspects of abortion. In the second trimester, abortion is largely completed through dilation and evacuation, which is the most common method of second trimester abortion. In these procedures, the cervix is first dilated with the use of osmotic, medical, or mechanical dilators, followed by evacuation of the uterus. Cervical preparation can be done the same day as a D&E or 1 to 2 days prior, and is key to the safety of the procedure as it reduces the risk of cervical injury and hemorrhage. Osmotic dilators are placed intracervically, similar to how one may place a Foley balloon for cervical ripening during labor. They absorb fluid and expand hygroscopically to facilitate cervical dilation. Additionally, the insertion of the lamin of the dilators releases prostaglandins, which can cause cervical shortening, softening, and essentially cervical ripening as well. There are currently 2 types of dilators that are available on the market. Laminaria is a natural dilator made of sterile seaweed and expand to 3 times their original size over a 12 to 24-hour period. These are usually placed overnight. Dilapan are synthetic dilators, which expand to 4 times their size in 4 to 6 hours. The photographs here show the 2 dilators before and after their full dilation. Osmotic dilators can be used safely in patients with the previa, PPROM, and history of a uterine scar. There's not currently high-quality evidence to support the use of one dilator over the other, and therefore the choice of dilator largely falls on the provider and what the institution has available. An important thing to note, however, is if you have access to both types of dilators, is that Dilapan requires less time and fewer dilators compared to laminaria to achieve dilation. Because Dilapan only requires 3 to 4 hours for its maximum dilation, it can facilitate a same-day procedure, compared to laminaria, which usually will require an overnight placement. Medications can also be used for cervical ripening. Misoprostol is a synthetic prostaglandin analog that I know most of us are very familiar with, that can be given buccally or vaginally. Many clinicians use misoprostol for same-day cervical prep as an alternative to overnight dilators in the early second trimester. For example, in our practice in Atlanta, we will give 400 micrograms of misoprostol about 2 to 3 hours before a procedure. Misoprostol can also be given in addition to osmotic dilators later in the second trimester. And unlike in term pregnancies, misoprostol is considered safe for those with prior uterine scar in the second trimester. Mifepristone is a selective progesterone receptor modulator with anti-progestin effects on the uterus. And because of that, it has significant cervical ripening effects. It's mostly known for its use in first trimester abortion, but mifepristone can also be given 24 hours prior to D&E. When given with osmotic dilators in the second trimester, it's been found to help with ease of dilation and can also decrease time of the procedure as well. There's also some data about mifepristone as an alternative to overnight dilators in the early second trimester as well. And lastly, mechanical dilation refers to using instruments to gradually opening the cervix. Many of you are familiar with rigid dilators such as Hagar and Pratt dilators shown here. These dilators are usually used without any other prep in the first 12 weeks of pregnancy. But many providers will use the larger dilators, such as Hagar's, to facilitate D&E for patients in higher gestational ages, usually in conjunction with osmotic dilators or prostaglandins as well. Intracervical Foleys is another method that's been studied as a means of facilitating same-day cervical prep for D&E. There's a retrospective study of patients at 18 to 22 weeks who presented for D&E services at an outpatient clinic. And the protocol detailed patients receiving an intracervical Foley followed by serial doses of misoprostol until the dilation was deemed effective by the physician performing the procedure. All patients in the study had complete same-day D&Es, with the majority of patients requiring only 2 doses of misoprostol. So another alternative to considering for a same-day procedure as well. This slide is what I like to call a one-pager, so just a summary slide of different cervical preparation regimens based on gestational durations. I want to add that this is only one example of a cervical prep regimen. Providers may tailor their cervical prep based on their prior training, their comfort level, legislative policies, and access for patients, as well as patient history components like history of prior C-section or parity. But I feel like overall this could be a useful way to consider different ways in which we can provide the same services for patients. Following cervical preparation, the uterus is then evacuated. First, we remove any dilators that we placed, and then an amniotomy is performed with forceps or aspiration. Mechanical dilation is then performed if needed to get the cervix adequately dilated for passage of instruments. And then fetal tissue is removed with the use of forceps or suction. Aspiration is then performed as a final step to ensure that the uterus is empty. Of note, routine sharp curettage during D&E is no longer recommended per WHO and SFP guidelines, as it carries risk of pain and scarring without added benefit compared to vacuum or suction aspiration alone. Now I'd like to move on to medication abortion in the second trimester. So I know many of you are probably familiar with the induction guidelines that ACOG has in their practice bulletin, but in the last year, SFP has updated their clinical recommendations on second trimester medication abortion, so I'll be focusing on those today. The SFP recommendations are specifically for pregnancies at 14 to 27 and 6 weeks of pregnancy. The most effective regimen for second trimester abortion is mifepristone 200 milligrams, followed in 24 hours by misoprostol. This regimen over multiple studies was associated with both higher rates of complete abortion and shorter time to completion compared to misoprostol alone. It's recommended to have an interval of 24 to 48 hours between mifepristone and misoprostol. However, concurrent use of the two medications is also acceptable and can be considered if an interval is not possible. In terms of recommended dosing of misoprostol, so from 14 to 24 weeks, misoprostol 400 micrograms, either buccal or vaginally, every 3 hours has been shown to be the most effective regimen. And for over 24 weeks, that dose can be lowered to 200 micrograms every 3 hours. Of note, a change from the ACOG guidelines is that a loading dose of misoprostol is no longer thought to improve abortion outcomes and can be excluded from your routine misoprostol dosing. Another change from ACOG is per the WHO and SFP guidelines, there is no longer a maximum recommended dose of misoprostol for second trimester abortion. For most patients, a complete abortion will happen within the first 48 hours of starting misoprostol. And if the abortion is not complete within that time period, a break or a stop in the misoprostol is not required. Some providers may consider a 12-hour or 24-hour break after like 5 doses of misoprostol, but this is certainly not required and meso can safely be continued. If an induction is taking longer than 48 hours, shared decision-making can be made with the patient about continuation of misoprostol, taking a break, or even considering surgical options at that time. If mifepristone is not available at the institution, the same doses of misoprostol noted above can be used. A few other protocols for second trimester medication abortion outline the use of oxytocin. Oxytocin is less effective than misoprostol given the lower concentration of receptors in the second trimester uterus for oxytocin. So its use is only recommended if misoprostol is not available or is contraindicated, such as in a patient with a true allergy to misoprostol. Intracervical Foley balloon can also be used along with misoprostol to help expedite expulsion, and it can be faster than using misoprostol alone. However, there's not really sufficient evidence to recommend routine amniotomy or the placement of osmotic dilators as clear benefits for patients undergoing second trimester abortion. Overall, the data has supported that misoprostol can safely be used in patients with prior uterine scar. Several meta-analyses in the past have quoted the risk of rupture to be less than 1%, but a more recent one has quoted a 1.1 risk of uterine rupture in patients with a prior cesarean section using the mifepristone and misoprostol regimen. For the SFP guidelines, one can consider lowering their misoprostol dose if a patient has multiple scars or a higher gestational duration in setting of a C-section, but this is based on expert opinion alone with limited data to support this. This page, excuse me, briefly summarizes the SFP and ACOG guidelines, and I've highlighted again some of the differences between the two, specifically that a loading dose is no longer recommended, and then a rest period is not thought to be necessary for misoprostol. When comparing a D&E versus an induction, it's important to consider the risk of both procedures. Overall, both methods are safe, but they both share a risk of hemorrhage, infection, cervical injury, and retained products. D&E carries a more unique complication of uterine perforation, whereas medication induction carries the risk of uterine rupture, especially for those with a prior scar. D&E tends to be faster with more predictable timing and can be completed in most outpatient clinical settings. While some outpatient abortion facilities may offer induction, most patients access induction abortion in the hospital settings, and therefore D&E tends to be more cost effective as well. In trials assessing patient preference, D&E appears to be strongly preferred when available. And lastly, while both methods share risk, the complication rate of D&E is overall lower than compared to medication abortion. This is thought to be due to higher rates of retained placenta, which is the most common complication of medication abortion and has been quoted to up to 29% in misoprostol-only regimens. I did want to briefly touch on the use of fetocidal agents. Fetocidal agents are intraamniotic or intracardiac injections that can cause fetal asystole and are used to induce fetal demise prior to an abortion. Many clinics or hospitals may require fetocidal injection at time of policy, at time of a procedure or induction abortion for a multitude of reasons. They may be to comply with a state or institutional policy, patient preference, for a peri-viable procedure. But there is insufficient evidence to routinely recommend this practice prior to abortion, and the procedure can carry risks such as nausea, vomiting, and extramural delivery. However, the SFP guidelines say that we can consider using this in the setting of a peri-viable delivery or for patient preference in certain situations as well. I now want to move on to thinking more about situations when we would discuss D&E versus induction in our next topic of managing complex and urgent uterine evacuation. And we'll start with this patient scenario, which I'm sure is one that many of y'all have encountered yourselves. So a 24-year-old G1P0 presents to OB triage at 21 weeks with fluid for 5 days. On her exam, she has positive nitrazine, ferning, and pooling consistent with ruptured membranes. An ultrasound shows a single fetus measuring 20 weeks with positive cardiac activity and an AFI of 3. She has mild abdominal tenderness, but no fevers or purulent discharge. And after counseling with her OB team, MFM, and NICU, she wants to proceed with pregnancy termination. So there are several factors that, as a complex family planner, when we get phone calls about these patients, that we take into account when assessing the best method for second trimester uterine evacuation. The patient's history and stability need to be taken into account. Additionally, it's important to assess provider comfort in performing D&E procedures and the availability of these providers. Are there people in the region who could accept a transfer if the patient is stable and desires surgical management? Abortion care also does not operate in a vacuum. There are institutional factors such as operating room availability, staff who feels comfortable providing this care, and institutional policies that can all affect what services are available to patients. Additionally, for patients who might be higher risk or who have urgent medical needs, we also need to think about institutional resources, such as the availability of a blood bank, ICU, and anesthesia services as well. And in the end, the patient preference and shared decision-making is key in all of this. Additionally, when we're considering the patient level factors, what I usually think about are things like, what's the patient's exam? Are they currently hemodynamically stable? And what are the other medical comorbidities that are going on with this patient that makes their procedure slightly higher risk than routine? All of these factors ultimately should be presented to the patient as part of the informed consent process, and the patient should be the driver of the decision based on their values and their desires. A few situations where D&E may be performed include patient preference, the desire to have a procedure under sedation or general anesthesia, and more predictable timing with the procedure versus an induction. This may be especially important in patients who might have certain medical comorbidities where having them go through a prolonged induction may not be completely safe. Medical indications where a D&E may be preferable include abnormal placentation, such as a previa and placenta occluta spectrum, and then use of anticoagulation, a bleeding disorder, or maternal cardiac disease, where similarly, less controlled environment, such as an induction, may not be ideal. An induction may be preferred for patients if they desire the experience of a vaginal delivery and want to see and hold an intact fetus. Additionally, an intact delivery will more easily facilitate an autopsy, especially in cases of an IUFD or fetal anomaly. Medication abortion may also be more successful than a procedure for those with uterine anomalies as well. And lastly, if providers not trained in D&E are available, induction may be a reasonable alternative for the safety of that patient. I wanted to highlight a few pearls for urgent procedural evacuation of the uterus in the second trimester. So for patients who require same-day evacuation with a closed cervix, dilapan and misoprostol can facilitate same-day cervical prep within 3 to 4 hours. And then a reminder that dilators can be placed safely in the setting of a previa or PPROM. Providers can also consider a Foley balloon with misoprostol for same-day cervical prep if dilapan is not available, as this can still facilitate dilation. And lastly, misoprostol can be given in the second trimester if a prior uterine scar is there. And of course, if a patient's cervix is already dilated, effaced, and soft, you can consider deferring the prep altogether and then mechanically dilating the patient in the operating room to facilitate a timely D&E for them. For urgent medication abortion, mifepristone prior to misoprostol is likely one of the most important things that you can do to increase their chances of successful induction and shorten their induction time. Another key point I really wanted to highlight is that pain control options for patients undergoing medication induction is key. And it's also important to decrease barriers to pain medication, as we know that these are oftentimes experienced more, or poor pain control is experienced more often by patients in marginalized groups. For example, say if you have a patient who presents to the ER with a miscarriage at 16 weeks who wants misoprostol induction and desires pain control with an epidural, they should try to be moved outside of the emergency room where their only pain management may be PRN IV medication. One can also discuss feticidal agents with the patient, depending on your institutional policies and practices. And you can also consider a Foley balloon with misoprostol to help expedite delivery, especially if mifepristone is not available. And lastly, patients should be prepared for surgical management if there are changes to maternal status or retained products of conception are present as well. In patients who present with a bleeding previa, it's important to assess the maternal hemodynamic status and cervical dilation with a gentle exam. Be sure to prepare for hemorrhage management and attain labs, including blood counts, coagulation studies, a type and screen, and cross for blood products. Patients should have good IV access and be started on volume repletion with fluids or blood products as needed. And if available, D&E is preferred. A couple notes I wanted to make here are that IV Pitocin and vasopressin in your paracervical block can be given to reduce the risk of hemorrhage, especially in patients where you're concerned about bleeding. Lastly, make sure that you prepare for your hemorrhage, which we will get into a little bit later in this talk. Another situation where oftentimes we have to discuss urgent uterine evacuation is in the setting of chorioamnionitis and sepsis, usually in the setting of PPROM. In the setting, we again want to assess maternal hemodynamic status and cervical dilation with an exam. Along with the labs that we spoke about before, it's also important to obtain lactic acid and vaginal cultures as part of your sepsis evaluation. Patients should have good IV access and started on volume repletion with fluids and IV antibiotics, regardless of the timing of the procedure. Patients with sepsis have an increased risk of hemorrhage, so be prepared for bleeding and consider crossing for blood products at this time as well. And lastly, as a reminder that post-placental IUDs are contraindicated in patients receiving a procedure or abortion for sepsis. After the abortion, patients should receive resources such as social work services and Champlain and bereavement services if desired. You can also offer footprints or a memory box for patients who may desire that as well. It's also important to discuss future pregnancy planning and offer immediate contraception if desired, but I also think it's key to pick up on patient cues and meet the patients where they are in terms of their own reproductive life planning and in their own stages of grieving and pregnancy loss as well. For abortions that are done for an IUFD or for fetal anomalies, patients can be offered genetic testing or autopsy. And lastly, many patients in the second trimester do experience symptoms of breast engorgement and even milk production. And so lactation suppression can be offered with cabergoline 1 milligram given as a tablet at the time of D&E or immediately after. Now I'll just switch gears a little bit and talk a little about management of abortion-related complications. So this is a good time to remind everyone that in general, abortion is safe and usually much safer than continuing a pregnancy. This is data from the most recent CDC reports on abortion and pregnancy-related mortality. And the abortion-related mortality from 2013, I believe, to 2021 was less than 1 death in 100,000 abortion versus the pregnancy-associated mortality rate in 2021 alone, which is 33 deaths in every 100,000 live births. And so again, for most of our patients, even the ones presenting for a quote-unquote routine abortion, abortion is generally safer than moving forward with a pregnancy. Post-abortion hemorrhage is one of the more common complications that we see, and it's defined as an EBL greater than 500 or bleeding that necessitates clinical response. Similar to a postpartum hemorrhage, causes for hemorrhage and abortion include atony, trauma, coagulopathy, and abnormal placentation. And risk factors that we consider include a history of C-section, gestational duration, and lack of good dilation. An important risk factor that I like to highlight is fetal demise, which not only increases your risk of bleeding, but also increases the odds of DIC. So it's important to remember for these patients, if they start to have bleeding during the procedure, to be prepared to correct coagulopathy as well. Hemorrhage prevention can help avoid serious complications, and a thorough history and exam can identify higher risk patients for abortion hemorrhage. For second trimester abortions, it's especially important to localize the placenta, especially in those with a prior uterine surgery. And adequate cervical dilation is key in decreasing the risk of bleeding. A few medications that we spoke about earlier that can help prophylactically reduce blood loss is dilute vasopressin and paracervical blocks, which has been shown to decrease bleeding with abortions greater than 14 weeks. IV oxytocin, we usually use the dose of 30 units and 500 cc's. At speculum insertion can also decrease bleeding at greater than 18 weeks gestation. Of note, more recent data has shown that prophylactic methotrexate does not help with blood loss at the time of abortion, and so it's no longer recommended per SFP. If you were to encounter hemorrhage during an abortion, treatment of hemorrhage is very similar to how we may treat a postpartum hemorrhage. So our initial assessment is including an exam and thinking about causes for bleeding, such as lacerations, a bimanual exam to assess for atony, and ultrasound to assess for hematometria or uterine trauma. For managing abortion-related hemorrhage, we generally use the same uterotonics used in postpartum hemorrhage. And this is the same exact chart I'm sure most of you are very familiar with from the ACOG postpartum hemorrhage practice bulletin. And these include medications like Methergin, Hemabate, misoprostol, and tranexamic acid. Of note, oxytocin, again, is not used as first line for most of us for treatment of hemorrhage in the second trimester, just because there aren't as many oxytocin receptors in the second trimester uterus. If your initial treatment with uterotonics by manual massage do not improve bleeding, then your second line treatment will include reaspiration and use of balloon tamponade, such as a Foley or Bakri balloon. At this stage, you should make sure that patients are receiving adequate volume repletion with fluids and blood, and that labs are being drawn to assess the patient's clinical status, including coagulation studies. Lastly, if your bleeding continues despite your secondary line of treatment, then we're going to be considering things like uterine artery embolization, laparoscopy and laparotomy, and finally hysterectomy as life-saving measures for that patient as well. Post-abortion infection is another complication that can be prevented via antibiotic prophylaxis. Of note, antibiotics are not recommended prior to medication abortion, but should be given routinely prior to surgical abortion. Our most commonly used regimens include doxycycline, azithromycin, and metronidazole. Symptoms of post-abortion infection can include pain, fevers, and bleeding within the first few days after abortion. And if you're concerned for infection postoperatively, it's important to rule out retained products. If patients are presenting with septic abortions specifically, which includes abnormal vital signs, evidence of retained products, broad spectrum antibiotics should be started and the uterus should be evacuated to ensure that there are no retained tissue. And lastly, uterine perforation is a rare but serious complication of surgical abortion. For perforations that occur at the fundus with a blood instrument such as a dilator, patients can safely be monitored with serial labs and exams if they are otherwise stable and not bleeding. If a patient, however, has a lateral perforation or a perforation is thought to be involving suction or forceps, these patients should have surgical exploration, which includes assessment of the bowel, bladder, and repair of any perforations at that time. So I know we just reviewed a lot of medical information and detail, but I did want to wrap up my talk with a note about policy, which I think is key in any talk about abortion care. So as I'm sure all of you know, the Dobbs versus Jackson Supreme Court decision in 2022 removed federal protections for abortion, and therefore states were allowed to have the ability to pass a wide range of abortion bans and restrictions following that decision. Currently, 13 states have full bans against abortion, and my home state, or current practice state of Georgia, currently has a ban on abortion following the detection of fetal cardiac activity, which is called a 6-week ban. What we know and what research has shown time and time again is that abortion restrictions are associated with increased risk of maternal mortality as well. Generally speaking, more restrictive states have consistently been shown to have higher rates of maternal mortality, with several studies showing this, including ones even before the Dobbs decision was passed. In my own state of Georgia, we have already begun to see firsthand the repercussions of abortion restrictions and increasingly restrictive abortion environments on maternal health. I'm sure some of you have seen these articles from ProPublica over the last few months of women who have died in Georgia recently after having possible delays in their care following miscarriages and abortions presenting to the ER, where providers were not sure or comfortable about which treatment options they could offer them under the current restrictive and incredibly punitive laws for providers. What we know is that restrictive abortion environments will only worsen reproductive healthcare disparities and will disproportionately affect marginalized communities. Restrictive abortion environments not only harm our patients, but they can also cause moral injury to us as providers as well. What we know is that restrictions on abortion are not based on medical science, and they focus on clinically irrelevant exceptions to abortion. And we know that in medicine, we do not operate solely in the space of exceptions. They create fear and confusion, not only for the patients, but for the clinicians who provide care. And physicians are therefore kept as gatekeepers to decide who qualifies for abortion care, who's sick enough, who has a good enough story to be able to be offered this care. Medical decision-making then is based on clinically ambiguous legal situations and is not patient-centered, nor is it evidence-based in situations under restrictive abortion laws. And ultimately, all of these different restrictions and all of this environment that produces fear and confusion results in increased maternal morbidity as well. So what can we do to support abortion access in this current environment? So I think for folks who operate in a variety of legal environments, it's important to build legal partnerships within and outside of your hospital systems. So think about who your allies are, who can help you expand care and expand access to patients in your systems. I also think it's important to think about building referral networks within your regions. So are there hospitals that don't have access to providing complex care in the second trimester? And are there ways in which you can facilitate access for patients to come to your facility to obtain that care safely? It's also important to remember to advocate to eliminate institutional policies that are stricter than your state law. So things that I think about are, does your hospital have access to mifepristone? Is that able to be given without restrictions for patients needing it for medication abortion, for miscarriages in the first and second trimester? Are there barriers to receiving contraception and sterilization in your hospitals? And are you able to also offer things like manual vacuum aspiration and mifepristone in the emergency room for patients undergoing a miscarriage as well? All of those are things that we can do as medical providers to increase access within our own systems that usually are not legislated by our state laws as well. I did want to briefly share some findings from my own fellowship project, which looked at how well abortion practices at tertiary care hospitals in New York actually aligned with our state laws. Similar to New Jersey, New York State has one of the most permissive abortion laws in the country, allowing abortion up to 28 weeks and later for many other indications, including maternal health and fetal indications. However, practicing as a fellow in New York, I found that oftentimes the hospitals themselves were more restrictive than our laws, and then hospitals would face barriers in providing this care. Our study was a mixed methods analysis where we spoke to MFMs, family planners, and genetic counselors at tertiary care centers all throughout the state. And what we found that even though the law permitted abortion care to happen past 24 weeks, many of the hospitals actually had barriers in providing this care, which included staff discomfort around abortion, institutional policies such as ethics committees, mandatory feticidal injection, and gestational duration cutoffs that were more restrictive than the state laws themselves were. And I think for me, it was a humbling reminder that despite being in a haven state or a safe state for abortion care, does not always mean that we have full protection access to reproductive health care. And there's still a lot of work that we can do to ensure that our patients have access to full evidence-based care. So in summary, I just wanted to share that shared decision-making is key when making these important decisions with your patients, that D&E overall has fewer risks compared to induction and is the preferred method for patients needing an urgent evacuation. However, if a D&E isn't feasible, adding mifepristone will shorten your induction time and allow patients to still deliver safely. In the setting of complications, remember your postpartum hemorrhage management, and you will be able to safely manage your hemorrhages and assess for uterine perforation as well. And lastly, just a reminder that increasing access to abortion care, regardless of our state climates, will improve maternal morbidity and mortality as well. Thank you again. I'm so happy to take any questions at this time and appreciate the time that you've given me today.
Thank you, Dr. Krishna, for that excellent lecture. I see that Dr. Bayat has her hand up.
Good morning. I'm going to try not to hog everything, but I wanted to take a second. Dr. Krishna, thank you again, not just for this talk, but for fully immersing yourself in fighting for your patients' most basic dignity, human rights, in an environment that has flung every single obstacle in your way. As a complex family planning specialist myself in an incredibly supportive institution where we have the real privilege of providing unapologetic abortion care through 26 weeks in a restriction-free state, I really can't fathom the weight you feel every single day on your shoulders. So I wanted to take a second and make sure that all of us truly recognize you, your work, and the emotional burden you carry as part of your job every single day. So thank you from the bottom of my heart. I have a few questions, but I'm going to start with one because I'm sure that the audience have other questions. But I wanted to give you a second and just sort of hear your thoughts. You know, as an OBGYN yourself in a state with a 6-week ban,
Mhm.
what are some of the things that you want to make sure OBGYNs who perhaps have not been supportive of abortion care can hear loud and clear from you today?
Yeah, thank you. And thank you for all of your comments and for the opportunity today. I really appreciate all of it. I think for me, such a big point, and one that I think being in Georgia specifically has really taught me, is truly just that there is really no way to unlink abortion from the general health care of our communities and the well-being of our communities as well. And I think what I have found is that access to abortion care is not just about that one moment in time of the patient in front of me who has a pregnancy that she cannot continue or they cannot continue and needing that abortion, but it's also about the ability for her to live that pregnancy out safely, the ability to her to have a future that feels promising financially for her goals, for her other children, for her safety. We see that in the data, right, of the links between abortion restrictions and maternal mortality. The Turnaway study, which I'm sure some of you are familiar with, that looks at patients who are turned away from abortion, have found that there are higher rates of depression, poverty, interpersonal violence for patients who have experienced a delay or experience being turned away from an abortion compared to those who are able to access an abortion at the time that they want. So I think really what it shows me is that I think oftentimes we operate in a world of abortion exceptionalism, right? Like a lot of things happen around abortion care that we just don't permit or allow for in other methods of healthcare. And I think that it's frustrating to me, specifically as someone who really engages in providing abortions, that like we can't do that because providing abortion for me is just as important as being able to provide preventative cancer screenings and vaccinations and prenatal care. And so it feels really unjust not only to like be able to turn those patients away, but to silo this component of their health out from like the rest of their general well-being, because we know that it's so important for the safety and the well-being of our communities as a whole. And being in a state, having malpractice in a few states where the ability to access that has been restricted, I can see the toll that it takes on these communities and on their safety, and the hoops that we have to go through to like fit those patients into those narrow exceptions and try to get them care outside of the state in order to like maintain that well-being and that safety for them. So I think that's something that I really want to, partake, is that abortion care doesn't just affect, me as a family planner, doesn't just affect us as OBGYNs, it really affects all of us, who are people who care for other people. And so it really affects all of us.
I have another question too, Dr. Ebert, if there isn't a hand up before mine.
Yes, go ahead.
Okay. Thank you. Those were such wise pearls and thoughts. So thank you for those too. I think one of the things that I struggle the most with is how to reconcile the fact that, D&Es in states where there are abortion bans, D&Es will be done for the sickest patients, right? Because that's when they meet their quote unquote medical exemptions. But for somebody who does a lot of D&Es, those are a lot of times the technically hardest cases to do. So something that really keeps me up at night is we have the sickest patients, and then they're going to be put in a situation where they have to have procedures done by people maybe who don't have a lot of volume for these procedures. And we're blessed to have still have fellowship sites, like you guys at Emory, in restrictive states where we still have that expertise. But I really feel genuine concern about what it will look like in the future when we have, even less D&E training.
Yeah.
Do you have any thoughts on, or, is Emory doing anything in particular about how we can preserve high quality and high volume D&E training when we are living in a world with abortion bans? So how can we make sure this procedure stays safe when we're able to do it, if we're not able to teach it routinely?
Yeah, no, I think that's a great question. And I don't know if I have a great answer for it, but I think a couple of things that I know that we've done in order to try to support, at least on the fellowship level, trying to support access to routine D&E volume is, obviously collaborating with some of our colleagues in states that are not as restrictive, that have higher D&E volume, so that, fellows can be able to get experiences. And this is something that I think fellows in some of the more restrictive states have been having to do, since the Dobbs decisions, certainly. So creating opportunities and, travel opportunities for fellows to be able to get that experience in higher volume settings. I certainly also do worry about the ripple effect, because we know that, medical students going into residency are now more concerned about being in restrictive states, and they're worried about getting adequate family planning training, and even worried about just, like, I think, the medical legal situation in states that are very restrictive around abortion and what that means. I think some of it too comes down to also being supportive of states that have, being supportive of, I think, clinicians and providers who work in states that have restrictive policies as well. So I think, some people feel like there's, I think, been the sentiment that we shouldn't abandon those who are still kind of operating, trying to provide good care in states that have some of these really frank restrictions. So I know there's been conversations about boycotting states, or boycotting conferences that happen in states with more restrictive abortion practices. And I think what I've heard from colleagues of mine who work in states, especially like Texas, that are even have even more like restrictive policies than we do, is don't abandon us. We are here, we're still providing care, our patients are here, we still have people here. Like, we need that support. We need that support in our communities in order to keep like providing that care, whether that's like making sure the patients get good ultrasounds, or making sure they can get referrals to where they need to be. And then I think it's also, knowing that D&E may not always be realistically able to be provided everywhere. I think it's also thinking about, like, how can we safely provide induction abortion to the best of our ability? So advocating for mifepristone in those systems where we can try to expedite abortion access. Do providers able to place Foley balloons and provide misoprostol to expedite their induction policies? And then also thinking about ways in which, if feasible, ways in which we can safely transfer patients for D&E, right? So when I was in fellowship, we certainly had patients who presented to hospitals where there was really minimal access to D&Es because of provider comfort and things like that. And so oftentimes they would be stabilized and sent to us in New York City, and we would, care for them there. But sometimes it would be helpful, like the providers at that other hospital would place laminaria, place dilators, and that's a helpful skill. So I think just sort of thinking about like different pieces of the puzzle in order to still allow for that access to happen, I think is still key, even if we're, I think, troubleshooting a little bit of how to make sure we, retain access to D&E services and all of that too.
I see that Dr. Rosen has his hand up.
Dr. Krishna, thank you for a really interesting talk, and thank you for like really the how-to of how to doing D&Es, and that's helpful for those of us who do them a little bit less often but still do them. This is my question. You are practicing in a state with very restrictive abortion laws. As a family planning doc, like how do you fill your time? Like, what do you do? Like, the things that mostly you would do are elective terminations up to and late. But now, like, do you have to fill in your time with like general OB, or what does life look like for a family planning specialist in Georgia?
Yeah, I'm very lucky to be at a incredibly supportive institution. We have Emory's Complex Family Planning Division has been a very long-standing division, and definitely has carved out its space and its role, I think, within our division, which I'm incredibly grateful for. And so our time breakdown is, I have a few days of my sort of general clinic where that's oftentimes a mix between complex like family planning consults, which can be patients that are coming in before the heartbeat mark, where we see for termination care, and then a mix of like general GYN contraception. I do try to like fill up a lot of my time with complex contraception as well, and then some annuals and other general gynecology. And then we also do spend some time at some of our outpatient abortion clinics here in Georgia, which we've still been able to support. And I think part of that is, again, we really try to figure out like what is the maximum that we can do under our laws, right? So we know that we have exceptions for fetal anomalies, we have exceptions for maternal health, and we really try to make sure that we can really offer patients as much as we can under those stipulations. So we do get a fair amount of referrals, especially because we are the primary complex family. I think we are the only complex family division in the state, but so we have a lot of providers who provide D&Es at Emory because of that, or a higher concentration of them. And so we get a lot of referrals from, all over the state, and sometimes in, from other places as well, for folks who have that criteria, like the fetal anomalies and patients with other sort of maternal health reasons. And I think a big key of why our division has been able to really, hold steady in the setting of all of this is that we have a lot of support and a lot of allyship with our other folks in our division, right? Like, it's not just the family planners trying to advocate for our role. It's also, our MFMs and people in the generalist division and, our administrators, like, really working together to make sure that this is an issue for all of us and not just something that just the family planning division has to work on. And I think that's something that's key, for anyone working in really any abortion state practice. Even in my study in New York, we found that was so important in making sure that abortion practices were preserved and were supported, is really having that like interdivision allyship as well.
Krishna, I want to ask you just one more question. Thank you for that answer. We've written a little bit at our institution. Dr. Bayat and I are co-authors on a paper on cesarean scar pregnancies in Georgia, and we surveyed providers in those states. That was Dr. Bayat's one of her major contributions to the paper. My question for you is, like, if you had a patient at 12 weeks that looked like she had a placenta accreta, probably a result of cesarean scar pregnancy, but the pregnancy looks viable, there's a pretty good chance that pregnancy would probably result in a live birth, but with serious maternal morbidity. Like, would you be allowed, would that be an exception in Georgia at this point, or what would you do with that patient?
Yeah, it's a good question. So oftentimes I would say, like, in general, these are pretty institution dependent situations. So the law has it has a definition around what is considered to be a maternal health emergency that would qualify for an abortion care. And that is therefore interpreted by the different institutions. So what, Emory interprets might be different than what, like Piedmont Hospital next door interprets. But generally in situations that where we have settings in which there is where we are concerned about increased maternal morbidity and mortality, is usually a situation that we will review with our colleagues, such as maternal fetal medicine, pediatrics. We'll review those cases together. And if there is felt to be a true, an elevated risk to the health and well-being of that patient, then we can proceed with that abortion. So oftentimes it's reviewed on a case-by-case basis. In general, cesarean scar ectopic pregnancies and ectopic pregnancies in general are not considered to be legally under the abortion law. So things that we have to do for abortion care, like a 24-hour consent and all of that, is not part of our management of abortion.
And I think I framed the question because I was super curious about, now you're past that cesarean scar, you've seen the results of that, potentially, probably viable. So yeah. I'm not sure if you would treat that differently. So at Emory, you could take care of that patient. Like, you guys have decided that we can help that patient terminate in that situation?
Yeah, sometimes, I mean, again, I'm sure it's always, situational, but I think if the case is reviewed and it's felt like this truly, has a high likelihood of morbidity, especially for that patient, then it's something that, we can be able to take care of either at our setting or, well, we do have in certain cases patients who go to one of our outpatient clinics as well. But yeah, something that we try to advocate for it if we can. But yeah, very much a case-by-case basis.
Thanks.
Yeah.
All right, Dr. Krishna. Well, thank you so much for this excellent talk. We very much appreciate it.
Thank you so much. I really appreciate the time.
All right, so we're going to end it here. I just hope everyone has a safe and successful day. Thank you.